if you normally give at least 2 to 3 treatments of it, they heal up beautiful and back to doing the things that they like to do. So I really enjoy treating that one because it's one that, man, you can get those guys better.
You're listening to the Ethos Athletes Podcast, where we believe that your health is the #1 resource you need to accomplish your dreams. My name is Dr. Matthew Hernandez, and I'm a physician dedicated to helping my patients maintain their active lifestyle and continue doing what they love. I'm sitting down with other experts so that we can provide our listeners with the knowledge they need to improve their health and live their best life. Hey everyone, this is Dr. Matt with the Ethos Athletes Podcast, and today we're going to be continuing our series on using regenerative medicine for joint pain. And for today's episode, we're going to be talking about treating the hip, foot, and ankle. And with this, just like the rest of our series, we have orthopedic surgeon and owner of Nashville Regenerative Orthopedics, Dr. Ethan Kellum, as our guest today. So Dr. Kellum, welcome to the show.
Hey, thank you so much, Matt. Appreciate it.
We've both had some experience with treating hip, knee, and ankle. And let's kind of start with the hip. A lot of times when people are going and discussing pain in their hip, there's 2 places that people describe when they walk into my office, and this is what I see the most of. And one is going to be where they're having pain inside the hip, and sometimes it comes on the front part, kind of where their leg creases with the pelvis, and they experience pain there. And usually that's a labral problem. And then the other time that they experience pain is a little bit more in the gluteal region, and they talk about having pain when they're sitting for a long time, stuff like that. And, once we rule out that it's not a back problem and all that, we usually find that it's a glute-med tendinosis. I know that you've seen both of these. So can you talk about how PRP or stem cell has helped with both of these? And then if you have any other injuries that you commonly see for the hip.
Yeah. So, PRP and stem cells, I think, have definitely revolutionized how I treat people around the hip. There's been times when, you'll very traditional kind of orthopedics or musculoskeletal medicine, you try the things like physical therapy and steroids and steroid injections. And PT is great, and sometimes will get us there. Steroid injections, they're the very typical thing that happens with them is you do the first one and they may get some relief from those things. But then, past that, if you do more than one injection, one, you really start to damage the tissue, and 2, you get less of an effect of those things. And so there's a lot of injuries and a lot of problems around there that can be very difficult to treat. And so when you use something like a PRP or stem cells that have just opened those things up. And so you run the gamut from treating things in the hip, like, hip OA, labral issues in the hip. Obviously, you can have greater trochanteric bursitis, so pain around that gluteus medius, but it's in that bursa. And then, of course, you have the tendons as far as the gluteus medius tendon and minimus, that you can have tendinosis there and can cause you issues. You've also got like the adductor tendons that run there kind of on the inside, right? And then you've got the iliopsoas tendon that kind of runs on the front, but closer to the inside. And so all of those things can be very difficult to treat just in general, when we're using very traditional things. And so when you add PRP or stem cells, that really opens up that treatment to really get much further down the road.
And what kind of success rates are you seeing with these injuries when you use regenerative therapies like this?
Yeah. So, to kind of talk globally, the soft tissue thing, so the gluteus medius minimus tendinosis, the greater trochanteric bursitis, the iliopsoas tendinitis, adductor tendinitis, hamstring stuff.
Yeah, I was going to mention hamstring too.
Yeah. So the proximal hamstring is a great one to treat with these treatments. And those things do very well. They respond very well to PRP. They respond very well to stem cells and PRP. But when you start to talk about things that deal with the joint, other than the labrum, if you're talking about just hip OA, hip OA is just hard. I don't know in your practice what you see, but in mine, it's, whereas I've got a knee, knee arthritis or shoulder, is going to be upwards to 70 to 90% of those people are going to respond very well. Hips are like in the 40%. It just doesn't, as far as hip osteoarthritis. And I would also probably include in there avascular necrosis too. That's another one that you can treat with these things.
Okay.
But hip OA and avascular necrosis don't respond as well, but they do respond, and they're definitely something that you can use to prevent surgery. So it's definitely worth trying.
Awesome. Yeah. So like in my practice, like you mentioned, hip OA can be a little difficult to treat. Have you seen it being beneficial to combo either stem cell or PRP with hyaluronic acid for the hip? And I mean, I know hyaluronic acid typically isn't used for it, but I've seen that be helpful in my practice with kind of helping relieve some of that irritation that's being caused.
Yeah, no, I definitely think that times, throwing everything at it, so to speak, and you definitely, there's research out there that says, oh, when you use PRP and hyaluronic acid, it works very well, and there's also research that's saying when you use both of those things that it doesn't help. So I think that it's worth trying, especially when dealing with the hip, and putting in some visco supplementation that has hyaluronic acid in there that the cartilage can use to build itself up. I think that's something to try, and it definitely doesn't help or hurt us. So definitely using that as you're trying to treat hip OA is something to do.
Awesome. In the case of hips, are you actually able to utilize these therapies after surgery as well? So let's say somebody needed some surgery of the hip, or let's even go with like a hamstring repair, a surgical hamstring repair. Do you utilize some of these therapies after the fact?
Yeah, no, that's definitely something that can happen, especially if you're repairing something, some kind of tendon or something like that, and you augment it with the stem cells and PRP. That helps those things heal much better. A lot of our data that we have comes from the shoulder with the rotator cuffs, right? So augmenting the rotator cuff with PRP or stem cells, we know that rotator cuff heals way better. And so the same thing with the hip as well. So if you got any of those soft tissues that you repaired, if you can augment that with stem cells, PRP, that's going to help that heal much faster and stronger, or heal period in some instances. So those things are very good to use. One of the interesting things is that you'll get a total hip done, some folks, and they'll still have issues, they'll still have pain, they'll have issues with that iliopsoas. And so these therapies can be something that can help those folks as well. Sometimes you'll get that total hip, you've had a great surgery, and you're still having issues, but you could be with that iliopsoas, and so you need to treat that as well.
Yeah, no, and that's a great point. I was going to ask you about that next. Was if people have had total hips and still have pain, is this something that they can potentially investigate further?
Yeah, definitely for that, like that iliopsoas issue. For more of like in the joint. Theoretically, it makes a lot of sense, but it's really hard when you put a needle inside a joint. Yeah. So, in my mind, I think that could help a lot, but we're not. We haven't gotten to the point where like just routinely do that when they've had.
Yeah. I mean, and again, kind of going back to like that SANS method of treating joint pain or approaching joint pain. If the joint or the articulation piece was replaced and you're still having pain, there's again something else going on. It's probably a stability problem, like you mentioned with the psoas, or there's something else going on that hasn't been addressed through the surgery.
Correct. Yeah. Very, very true.
Now, for the individuals that you've treated with hamstring tendinosis, I've done a few. I've done some of these in my practice, and these seem to take forever to heal. Out of all the regenerative medicine procedures that I've done, hamstring seems to take the longest to heal. Is that kind of the same experience that you've had, or?
Hamstrings have been. They're one of my favorite things to treat, because normally when they come in, they've been dealing with this for a long time, and they've done all the therapy, they've seen all the people, and just not getting better. And what I've found with that is that it does take a little while, but if you normally give at least 2 to 3 treatments of it, they heal up beautiful and back to doing the things that they like to do. So I really enjoy treating that one, because it's one that, you can get those guys better. And just, because, having a proximal hamstring issue and trying to just live life in general hurts like the dickens.
Yeah, for sure.
So yeah, it can be, it can definitely be, I think doing one treatment, it gets you there, but doing 2 to 3 really makes it better.
And just so we have listeners that probably have a hamstring problem and don't even realize it. What are some of the symptoms that these patients typically see?
Yeah, so they're going to have posterior pain as far as kind of right under the butt cheek, and they're going to have issues with running, doing most because the hamstring's involved in everything.
Right.
And so whether it's squatting, running, jumping, twisting, they're going to feel just this nagging pain in that butt crease in the back, and it can be anywhere from sharp to dull, and sometimes it could radiate down their leg, and so. They'll have some, it'll just nag them. They know when it's happening.
Yeah, for sure. Now, when you go and do this particular treatment for the hamstring, you do stem cell or PRP. Does the leg have to be immobilized completely? Like, do they have to be in crutches for X amount of time, or can they go back to walking normal? And obviously not running yet because we're allowing the tissue to recover. But
yeah, so I normally allow them to, if they can walk out of here, walk the next few days. I don't necessarily have them off of it.
Right.
Sometimes they may need some crutches or things like that just for comfort. But, I believe that tissues and joints do better when they're moving.
Yeah, I agree.
But that moving has to be guarded to some degree. So I have them rest for a couple of weeks, and then we start some very focused and gentle range of motion strengthening through physical therapy and other modalities for the next 6. And then, they're 8 weeks after that, and then kind of cut them loose as long as it doesn't hurt them too bad. And they just progress from there.
Okay, no, that's good. Yeah, I had a patient who I think her PT convinced her that she had to be in crutches after I did her treatment. And I was like, no, you're fine. Don't go run, but you can walk and do your normal stuff. And she was like, well, he keeps telling me I need to be in crutches. And I was like, no, you're okay. And so I wanted, I hadn't heard of a protocol that involved that, but I figured I'd ask you, and maybe you could shed some light on it, or if yours was slightly different.
Yeah. No, I think that, like I said, once again, motion to joints and tendons are good, that they become strong. Sometimes they just need to heal a little bit, and they need something to help them heal. And so, I think motion is good. Yeah,
that's perfect. And so you're seeing about three treatments. Are you using PRP or stem cell for the hamstring?
So it just depends. I use both. Obviously, stem cells are the king, right? And they help the most. And so that really is, if you can treat with that, it's great. But if I use just PRP, then I definitely like to see 2 to 3 treatments with that. With stem cells, you can do a little less. Okay,
cool, perfect. Before we move on to the foot and ankle, I have a follow-up question from our last podcast where we talked about knee pain. We talked about using PRP and stem cell for treating knee pain that could be due to meniscus problems, right? And we talked about how going and shaving down or going and doing a scoping of the knee where you take out some of the meniscus isn't the best idea always, right?
Right.
What about in instances where there's like a flap and the meniscus is getting caught? How do you typically approach those?
That's definitely a tough one, right? So if you got a flap and that is getting caught, then that's, it becomes a mechanical issue. It can get stuck and things like that. And so that's, in those cases, you potentially would definitely want to think about, hey, do we scope this and do something about it, right? Okay. I'm still of the belief that even if there's a flap, it's better off if you can repair that if you can. Some form or fashion. I really believe that versus taking it out, because I just know that when you take that out,
a bunch of other problems happen.
A bunch of other problems are going to happen. So I definitely understand if you got a flap that's catching in there, then you got to try to get that to where it's not catching, right? And so sometimes you have to surgically do that. But even if you're surgically doing that, you really want to just repair that. And once again, we're talking about a degenerative knee, so someone that's 35 and above, 40 and above, versus an acute or someone that's in their 20s or early 30s that have this issue. Those are very different beasts. And so we definitely want to understand that on one side we have a tear that needs to be repaired for sure in a young person.
Right.
I think the same goes for older people. We just got to get our thinking down that road. But for me, as far as how, I see patients, there's sometimes that some of that stuff is, it's not repairable, right? So you either do a couple things. You either leave the tissue or you debride it. But, I really think hard before I debride it.
Yeah. Yeah, no, and I think that's a good point to make for sure. How about, have you ever had the instance where someone could be they're going through PRP treatment for a meniscus or stem cell for a meniscus injury or a meniscal tear, and then that flap kind of occurs, and they have pinching in between treatments and stuff? Do you go in surgically and again fix that, or do you kind of give them some sort of exercise to do or some sort of movement to do to help with it?
Yeah, I mean, if we've kind of already initiated treatment and we're having that issue, then we try not to disturb the inside of that knee. So I'll wait a while, and if it gets to the point that we need to do something about it, then we'll address it then. But I really try to allow it to go for just a little while.
Cool, perfect.
Messing with it, and kind of that note, I don't know if there's a paper that just came out about trepanation of the for meniscal tears and how that percutaneously with PRP and people are doing great. And it's what anecdotally I've been doing and that I see, right, also from the research, but it's great to have more research about these things. So it's a really good paper that's out there currently.
Yeah, absolutely. That's cool. And then now let's go into foot and ankle. So there's a lot that can go on in this area.
That old foot.
Yeah. So let's start with one of the common ones, which would be like Achilles tendinosis or tendinitis. Yeah. How often are you seeing these? How well is regenerative medicine helping these injuries in your experience?
So Achilles tendinosis, it holds a special place in my heart as far as regenerative medicine goes, because this was the pathology that my very first patient in practice that I treated on my own with the regenerative procedure. There's a guy that he had come to me. He had seen two other orthopedic surgeons, and he was a marathon runner and had been treated in the boot, all the therapy, the grass, and I'm talking about all the modalities, all the techniques, and not getting better. You know how runners are. Runners are just crazy people.
Yeah, for sure.
Not crazy bad, but
they don't stop.
Crazy bad. Yeah, they just they love to run, and so he came to me and said, "Okay, hey, what can you do for this?" And I'm thinking, man, you've seen everybody in the world, and so we talked, and as we talked, I said, well, I just gotten out of fellowship, and I said, well, and learned about those techniques and been doing those things in fellowship, and I said, well, we can try this thing called PRP, and I said, but insurance doesn't cover it, and blah blah blah, and of course, once again, runners, man, he said, yeah, let's do it.
Yeah. So
treated him, the whole deal, treated him with PRP, and 12 weeks he's back to running marathons. So, Achilles tendinitis, the tendinosis, can respond very well to these things, and it's one of the in my mind, it's one of the easier ones to treat, and that can respond. And does everybody respond? No, right. But people do very well with this, and I've seen it where we talk about how with arthritis, it's doing stem cells PRP, not a cure, right?
Right.
But man, you can make an Achilles look like normal on an MRI, which is really cool.
Yeah. So with the ones the patients that didn't respond to stem cell or PRP in this case, what did you end up finding was part of the problem, that that it wasn't just the tendon in that case, right? Like there was more to it.
Well, yeah, and I'm actually trying to think about the folks that I've treated that haven't responded. I would say that just about all of them did. If they didn't get all the way better, they got significantly better.
No, that's awesome.
And so I can't really, as long as we have the diagnosis right, most of them respond extremely well to this.
Yeah, that's awesome. Like I've talked to other doctors where they responded really, or for individuals who didn't respond that still had an Achilles problem, they usually had some sort of instability in the foot that was kind of causing the issue. So then that kind of takes us to another part of the foot and ankle, which is just all the different ligaments that kind of surround the foot. That we have a crap load of them in there.
Yeah,
and just the overall stability of the foot. How have you seen this impacted by regenerative medicine?
Yeah, so instability of the ankle is huge, right? And it stems from when we're 12, 13, 14, 15 playing basketball and sports and having where we roll our ankles and things. And there's those, the ATFL, PTFL, and the CFL, all those on the lateral side. Of course, you got the deltoid ligament that's on the inside. And so when things are unstable, you get pain from that and issues. And so usually if I'm treating something around the ankle, I usually always try to treat those ligaments because stability is going to just help us down the road, right? And so those things are very, very important. But yeah, treating the ATFL, CFL, PFL, those things are, it's really, really important to do.
Yeah, and I'm sure you get this feedback as well. Like I had a personal experience with this where there was I think like a 2-month span where I was playing basketball like multiple times in that 2-month span, and I think I sprained my ankle or rolled my ankle probably like 4 or 5 times in that 2-month span.
Mm-hmm.
And after that, on month 3, when I was kind of like somewhat back to normal, I was going and it just felt unstable. I mean, I felt like if I stepped on like a pebble wrong, it would just give out again. And going and getting that treated with PRP really helped. And I don't have that problem anymore. And I have patients kind of tell me the same thing, that when they have these instability issues is, this, like, they're scared to like jump or anything, because if they land wrong, they know they're gone at that point. And if you can stabilize everything with therapies, then that goes away, and you can definitely feel that, and you're not as like self-conscious of it, which a lot of people worry about.
Yeah, no, and it just makes things a lot better. And it goes back to our SANS technique, right? So you got to address that stability of things. And when you do, you can help decrease that pain.
Yeah, for sure. Kind of sticking to, we talked about Achilles tendinosis. You also mentioned treating peroneal tendons as well.
Yeah.
Right. So what does that pain look like when people are having it? And then you can kind of explain what they are, because peroneals are usually not something that people are familiar with. So
so there's 2 muscles on the side, on the outside of the leg, that go around that bony prominence at the ankle, and one's called the peroneus brevis and one's called the peroneus longus. And the brevis is closer to the bone, and the longus runs, and they attach into the foot. But as they get around that ankle, they become tendinous, and they can get beat up and torn and frayed and stuff like that. And so you'll have pain, lateral pain on the outside of that ankle. And so, it's, when you try to kind of evert that foot or move that foot out or even in, you can feel pain out there with those tendons being damaged. And so those are, those, once again, tendons are something that responds very well to those. And so you'll get little partial tears in there, or fraying, or longitudinal tears. And so surgically what we do is we go in there and we try to repair that. And so, trying to save a surgery and do something like a regenerative procedure can help very well. And so injecting those materials in those tendons can help out quite a bit.
In this case, is it again kind of similar to the Achilles, where it's 2-3 treatments and you notice?
It's especially if you're treating with just PRP alone. I think stem cells, you can get much further down the road quicker with less. But and sometimes it, one is plenty. But I always think 2 to 3 in my mind, just to really get them there.
Okay. So we talked about Achilles, ankle stability with the ligaments, peroneals. We have plantar fascia as well. Yeah. What's your experience been with plantar fascia for treating the plantar fascia?
Yeah. So, it's one that's, that plagues a lot of people, but it's easy to get to, easy to treat. And once again, people do very well. It's, the plantar fascia essentially, it's really that tendinosis, right? It's that you got these little partial tears, this fraying, and people, when they get, first out of bed, I mean, it hurts to put their feet on the ground. And so it's very resistant to our very normal treatments, right? It just doesn't, PT, stretching, wearing boots at night. I mean, there's all sorts of things that just don't work.
Yeah.
And so once again, it's kind of like that Achilles tendonitis. It's like, wow, this can really put people on a good path and in a good way. And so, the hardest thing about plantar fasciitis and treating with regenerative is getting the needle in the bottom of your foot. Most people don't go for that.
Yeah, for sure.
It hurts quite a bit, but it's very doable. Very doable.
Yeah. Typically, when I do this particular procedure on people, I'll go and I have them in a boot, like a short cam boot for, I don't know, maybe like 2 weeks on the first treatment. Is that something that you've seen common, or that you commonly do, or do you just kind of let them go back to their normal shoes?
I definitely will wear a boot for just a little bit. I'm not a big fan of boots, and this probably differs than most of our colleagues and us, right? So I think most guys do exactly what you do, as far as having them in a boot for a while. But I'm not a big fan of it. Because I know it's going to, the longer they wear that boot, that ankle's going to have a problem, that knee is going to have a problem, the hip on the other side. And so I may have them in it for comfort for a couple of days, but then when that pain subsides, I try to get them out of it fairly quickly.
Yeah, and I think it's important to note, I had a patient who was having plantar fasciitis, and she had been seeing another doctor before she came to see me. And I think they had her in a boot for 3 months or something like that.
A long time.
Yeah, and by the time she was out, I mean, you could tell her muscles had weakened. She had all these extra problems. Yeah, and so I mean, fortunately now the treatments worked. The treatment that we did on her worked so well that she finished a Grand Canyon rim to rim to rim hike.
Excellent.
Like just a few months ago. So that was pretty cool.
And some of these things are anecdotal, right? And I try to look at literature. We used to, for the longest time, when people had an ankle sprain, we'd put them in a cam boot and we'd do it for 3 weeks or so. What we found was that people did worse when that ankle was immobilized.
Right.
And so I kind of take all of those things and add it to and that goes back to my whole deal about just, joints and tissues respond to motion, to stress, and it's actually good. I definitely think that sometimes we got to slow it down a little bit, but continue to move things, and having that pressure, the body actually responds better.
Yeah, no, absolutely. Do you have any other injuries that you've seen or that you treat on the foot and ankle that we haven't mentioned yet?
Well, we've gone through what we've gone peroneal tendons, we've done Achilles tendonitis, we've looked at plantar fasciitis. There's tarsal syndrome on the ankle.
Talk about that one.
Well, just the tibial nerve that goes through there, and having symptoms of pain, with that kind of on the inside medial part of the foot down below, that can also kind of mimic plantar fasciitis. So that's one that you can treat. And then you got like a Morton's neuroma that you can treat. Sometimes you'll have the hallux rigidus, right, which is that first metatarsal that just you got arthritis that's in there that you can potentially treat. Obviously, arthritis within the ankle joint itself, osteochondral defects, things of this nature, you can also treat with stem cells, PRP. And then, you've got all the joints, which are small, but nonetheless can cause some issues. So
for sure. So in the case of like tarsal tunnel, are you going and doing platelet lysate with that, or? Yeah.
So I think that's So you got entrapment of that tibial nerve over there. Using platelet lysate can really help that.
Okay. And is there any type of surgical release that you do of that entrapment, or do you just
try not to? Obviously, if it doesn't respond to something like platelets, then you would potentially consider that. But our goal is always to keep people out of the operating room and trying to do these things first.
Yeah, no, that's perfect. Awesome. Well, I think we covered a lot today. So we talked about using regenerative medicine to treat hip labrum, osteoarthritis, a bunch of different types of tendinosis, such as the hamstring, adductor, psoas, all those things. And then briefly went back to discussing the knee from the last one and how to approach that a little bit differently. And then, and there's a lot of stuff we can do with the foot and ankle, primarily with the Achilles, the peroneal tendons, plantar fascia, just ankle stability in general. You mentioned the tarsal tunnel syndrome, and then neuromas, osteoarthritis, all that. So a lot of things that we can do with these therapies to help people get out of pain and doing the stuff they love again. Dr. Kellum, do you have anything else you'd like to add?
No, I think we covered a lot today. It was good to talk about all these things. Those are fun things to treat.
We'll go ahead and leave y'all with the information that we provided. And Dr. Kellum, thank you again for being on this show.
No, thanks for having me, man. I always enjoy it.
Awesome. Well, everyone, hope you enjoyed the podcast, and we'll catch you on the next one.